girl. Shruti, who is Alice?
A fictional character.
A fictional character. Okay. Anybody else wants to take a guess at this? Guru Shekhar?
Maybe real girl.
Who said that? Guru Shekhar? Yes.
Real.
Yeah. Alice is a real girl. And the real girl was a girl by the name of Alice Pleasance Liddell. Alice Pleasance Liddell was the girl who was the daughter of the dean of an Oxford college, at which this young man, Lewis Carroll, whose real name was Samuel E. Dodson, was a lecturer. And he used to go over to the dean's bungalow, and you know that deans often have a bungalow, and he would tell stories to this little girl, Alice. And what the stories that he told were penned down into two very famous books, and they were known as Alice's Adventures in Wonderland and Through the Looking Glass and What Alice Found There. Now, he took this as his pen name, Lewis Carroll. His real name was Samuel L. Dodson. Okay, and that's why they write alias Lewis Carroll. There are many very interesting characters in these two books. One of them is Walrus and the Carpenter, and one of my slide seminars has been of shoes and ships and sealing wax and cabbages and kings, in which we talked about miscellaneous tumors, because that's what the Walrus and the Carpenter were doing. They were talking about miscellaneous subjects. Then there is the Mad Hatter, there's the Cheshire Cat, who's always smiling up there on a tree, and then there is the Red Queen, who's a very imperious woman. And if any of you are interested, there is what is called in science the Red Queen hypothesis, because this comes from what the Red Queen used to say. It says it takes all the running you can do to keep in the same place. If you want to get somewhere else, you must run at least twice as fast as that. So now, if you're interested, and I've just given you a little taste of Alice, and in science there is something called the Red Queen hypothesis. I'm not going to tell you about it because it'll just prolong the time. But if you're interested, you can go and find out what the Red Queen hypothesis is, and following that, there is the Black Queen hypothesis. All right, so now let's get to our cases, and we will take case 1A and case 1B. Now, who wants to start with case 1A and 1B? Shruti, would you like to start, please? Shruti, are you there?
Yes, ma'am. Yes, ma'am. I'm here only. Case 1A, it says 18-year-old male who had undergone wide localization of the tongue region.
Right, and what about case 1B?
It says it's a 44-year-old female with distal pancreatectomy.
All right, very good. So now you have, I hope you've seen the slides, Shruti, have you?
Ma'am, I did see the slides, but I was not very...
Well, you have to start describing them, Shruti. You've seen the slides. Yes, I'm not asking you about the diagnosis. I told all of you in the beginning that it's not the diagnosis that I'm really interested in. It is how you make observations, what kind of interpretations you make on the observations, and then the diagnosis will follow suit. Okay, all right. Come on, Shruti. Now you have to describe case 1A and case 1B, because that's what you're going to do. You are the person in charge of this Tweedledum and this Tweedledee. All right, come on, case 1A. This is a fairly low power view, so come on, Shruti.
I'm sorry, ma'am, I didn't write the description, but what I can see is...
You don't have to write a description, Shruti. You're seeing it over here. You saw this. This is what was shared with you. So come on.
Yes, ma'am. Ma'am, I can see part of epidermis. Like the...
Do you know what the history is? Can I go back, please?
Yes, ma'am. Tongue, ma'am. Wide localization of tongue.
Extension of a tongue lesion. All right,
Yes,
so come on.
Ma'am, I can see the... mucosal...
Come on. You said you saw epidermis.
Yes, ma'am.
Do you want to change that?
Yes, ma'am.
Yes, what is it that you're seeing on the left-hand side?
Ma'am, mucosal...
You are seeing mucosa. What
Yes,
mucosa is that? Come on, it's not difficult, and you don't have to feel everybody's in the same boat. So please tell me what mucosa is that? Can I just request Sukanya? Somebody called Sukanya is asking for annotation. Okay, now let me just explain to everybody. I'm not going to allow it because only the students can do that. Sukanya, you either by mistake or by intention have pressed a small little icon that is present on your screen, which looks like a little worm or a very small snake. So this is not just for Sukanya, but for anybody else. Please do not press that particular icon. All right? Thank you very much. Yes, come on, Shruti. Tell me, you said that you retracted the word epidermis. You said this is a mucosa, right? So which kind of mucosa are you seeing, Shruti? What kind of mucosa? Now, that's not very difficult, right, Shruti? You see my, do you see my cursor? You see the arrow, my cursor?
Yes, ma'am. Yes, ma'am.
So what is it pointing to, Shruti? What is it? What is this?
Mucosa.
Who is that? Ismail? Is that Ismail?
Oral mucosa.
This is oral mucosa. Oh, Guru Shekhar is saying that. Okay, very good. So do you agree with that, Shruti?
Yes, ma'am. Stratified squamous. The squamous.
Stratified squamous what? What is stratified squamous? Guru Shekhar said that he is seeing squamous mucosa. Do you agree with him, Shruti?
Yes,
Is this squamous mucosa? Okay.
Yes,
Yeah, you agree with him. Very good, Shruti. So when I asked you, what are you seeing here? You said stratified squamous epithelium. Now, Shruti, I want you to think carefully and then answer. Is an epithelium the same as mucosa?
In case of tongue, we don't use epidermis. It's for the skin.
I did not say epidermis, Shruti. Just listen to me carefully. All right. Is squamous epithelium or mucosa the same thing? Is mucosa the same as epithelium?
No, ma'am.
No. So then tell me, what is epithelium and what is mucosa? How do you define an epithelium and how do you define a mucosa? Or do you use the terms interchangeably?
No, ma'am. Ma'am, mucosa is the innermost lining of GI tract, whereas
So you don't get mucosa anywhere else. It has to be only in the GI tract. Do you get mucosa anywhere else, Shruti?
Yes,
Do
ma'am.
you get a mucosa anywhere else? Okay, anybody wants to help Shruti to answer this question? Number one, do you get mucosa anywhere else? Anybody? Ashwin? Ashwin, do you want to answer the question?
In exposed parts, we have
Exposed parts, yes. What happens in exposed parts? Guru Shekhar, you use the word mucosa. Will you please tell everybody what is a mucosa?
Mucosal membrane will be the glands will be present, secreting glands somewhere.
Glands will be present. So every mucosa must have glands. Yes?
Yes, ma'am.
Are you absolutely certain that what you're saying is true? Yeah. Do you have mucosa on the gingiva, Guru Shekhar? You know what is the gingiva?
Yes, ma'am.
What is it? Where do you find gingiva? Where do you find gingiva?
Oral.
In the oral cavity. Where in the oral cavity do you find gingiva, Guru Shekhar? You know that gingiva is the same as gum. Yeah. Where are your gums, Guru Shekhar? The gum is where? It's on the alveolus, right? You know what is the alveolus?
Yes, ma'am.
The alveolus is that portion of the mandible which bears the teeth. It's also the portion of the maxilla that bears the teeth. No, that is known as the alveolus, and covering the alveolus is alveolar mucosa, also known as gingiva, also known as gum. Yes, do you agree, Guru Shekhar?
Yes, I agree.
Okay, very good. So, if that's the case, do you have on your gum, on your gingiva, are there any glands over there? Yeah, you see some glands on the gum? The answer is what? Anybody can answer. Yeah, Asma, do you have glands on the gingiva? You do? Asma, are you there?
Yes, ma'am, I'm here.
Yeah, so very much. So now tell us, you must have done, because you're at Tata Hospital, you've been doing grossing, right, Asma?
Yes.
Right. And so the grossing is often of mandibulectomies, and
Yes.
you take sections of the mandibulectomies, and you must have seen what these sections look like, correct?
Yes, ma'am.
Right. So do you see any
No.
glands, mucus glands, or whatever you want to call them, in the gingiva?
No, ma'am.
You don't. So now, Guru Shekhar, just see, you don't see glands in the gingiva. So what is a mucosa? What is a mucosa? I think that I think it's important for you guys to understand what is the mucosa. What you have on the outer part of your body is skin, right? It has an epidermis and it has a dermis. The epidermis is the lining composed of epithelial cells, okay, which happen to be squamous. Now, when you can get to the inner lining of whether it is the mouth or it is the respiratory system or the gastrointestinal system, yeah, we call that lining, we call it a mucosa. Yes. And just like the skin has got two components, what are the two components of the skin, please, Guru Shekhar?
Dermis and
Yes. What is it? Sorry, loudly?
epidermis and
Dermis. Yes. And what's the difference between the epidermis and the dermis?
the dermis has smooth muscle layer and so much
1 minute. The dermis has smooth muscle in it? Does it?
collagen, most abundant collagen will be present.
It has abundant collagen. Okay. Somebody wants to help Guru Shekhar out? Shruti, what does the dermis have?
Appendigeal organ, appendigeal.
Yes.
gland.
But essentially, what is the dermis? It is stuffed with appendages? No.
Ma'am,
What does the dermis
fibrocollagen.
do? So the dermis has a stroma. It is essentially composed of stroma and stromal cells, in which, yes, you have the appendages. And those stroma and stromal cells will vary from which part of the skin it is and which part of the dermis it is. You have what is called the papillary dermis and you have what is called the reticular dermis. And the reticular dermis has got very, very a thick collagen, and the other part, that's the papillary dermis, has got a loose areolar tissue. But that's the dermis. And what's the epidermis, Guru Shekhar?
Epidermis is composed of stratum corneum, stratum granulosum, stratum
It
spinosum.
is an epithelium. Okay, so the epidermis is an epithelium, and the dermis is essentially a supporting structure for that epithelium, which is mainly stromal in origin. Now think about the mucosa. What should the mucosa therefore contain? Yeah, Shruti?
Epithelium, and then
Right.
underlying stroma.
And there should be an underlying stroma. Yes, and that stromal structure, that supporting structure, varies from place to place. It is different in the gastrointestinal tract. It is different in the oral cavity. It is different in the respiratory system. It is different in the various internal structures that have a cavity, and which have a lining. So now, Shruti, can you please describe what you're seeing in case number 1A? So what are you seeing? You are told that this was the tongue. So now will you please describe this?
Ma'am, I can see extensive epithelial proliferation.
Okay.
I can see.
You're seeing an epithelial proliferation.
Yes, ma'am.
Okay.
Ma'am, there are some cystic structures. I think.
Okay. So you're
Okay.
seeing epithelial, what you're calling proliferation, and there are cystic structures. But where are the cystic structures? Where are the cystic structures? Where are they situated? These cystic structures, Shruti?
Ma'am, on the
On? Are they on? You know what is the
right.
meaning of on, no? On means on top of. So you're finding some cystic structures on top of. Is
In
that
the
right?
mucosal lining, cystic structures are in the mucosal lining.
They are in the mucosal lining. So I think that we have starting to have problems. See, this is what I have been saying all along. You have to learn how to observe, and you have to learn how to interpret what you observe. Now, just to tell you, Asma, can you take a stab at this, please?
Sure.
Come on, Asma, please describe what you're seeing over here.
I think it's a proliferative growth and the mucosa overlying it is normal and their cystic lesion are submucosally located.
So you think it is a proliferative growth, okay?
That's
What is proliferating, Asma?
I think the It's adjacent mucosa and it's going above the mucosa.
Yes, something is going above the mucosa. But what I can see, and I'm hoping that all of you can see, is that there is a fairly normal squamous lining, which is a squamous epithelium. Yes.
Yes.
Deep to which there is a mucosa, a sub-epithelial layer. Yes. And in that sub-epithelial layer, there are these cystic spaces. No, you can see them. Absolutely seen in the sub-epithelial layer. So you have an epithelium which is squamous, and in the sub-epithelial layer, yes, you have cystic spaces. All right. But is that epithelium proliferated? Unlikely, no, because it has the same thickness as you would expect in normal tongue epithelium. In fact, it may be actually less thick than the normal tongue epithelium. But that epithelium is thrown into it's thrown into papillary projections. That's what it is. That's what is happening. That this epithelium is thrown into papillary projections because something is occupying the sub-epithelial tissue. Does that make sense to you now, Shruti? Yeah. So there is a papillary projection of the squamous lining epithelium of the tongue, and it is thrown into these papillae. You can see them. They're like little finger-like projections. Okay, but it's not the epithelium that is actually proliferating. So this is not like a squamous papilloma where the epithelium is proliferating. What is actually happening is that something underneath that epithelium, which is in the sub-epithelial tissue, is pushing this epithelium into these kind of folds. Okay, does it make sense now to you guys? And that's how I would describe it. That is my way of making the observations and the interpretations of whatever I have observed. Okay, now come on, Shruti. What do you see in case B? 1B.
Ma'am, again, there are
Yes.
two areas to be observed.
Yes.
One is the outer one, which again has multiple cystic structures, and the inside one, it looks more like a solid architecture with a lot of cells.
Okay. So
And-
do you know what we said about this case?
Yes,
What
ma'am,
was it?
44-year-old female with distal pancreatectomy.
Exactly. So now, what do you think is this solid area that you're seeing over here? What is the solid area? You can see my
Yes, ma'am.
you can see my arrow, right?
Yes, ma'am.
Yeah, very good. So what is that area?
Pancreatic tissue.
It's pancreatic tissue. So I can see pancreatic tissue, and I can see a well demarcated zone, which is it is clearly demarcated from the pancreas. Yes, you can see that. Yes,
Yes.
that's very good. That has these cystic spaces. All right. So now we have got cystic spaces in case 1A, and we've got cystic spaces in case 1B. All right. Now come on, Shruti. You can see this at higher power. Now you shouldn't have any problems at all. Come on. Now describe the cystic spaces that you are seeing in 1A and the cystic spaces that you are seeing in 1B.
Uh,
Can you see the cystic spaces?
Yes, ma'am.
Very good. So come on.
Ma'am, in cystic cases in 1A, it appears to be filled with some
Yes.
Uh,
Filled with what?
homogeneous eosinophilic material,
All right.
and it is not well demarcated by any lining. Whereas in case 1B, I can appreciate the spaces are well lined by the cells.
Lined
And,
by what?
a single layer of squamous cells, and there is some dirty
Single layer of squamous cells. Acha, why did you say that there was squamous cells, Shruti? What made you think that there's a single layer of squamous cells?
Ma'am, I can appreciate a single layer and it appears to be flattened. So
Yeah, so if it is flattened and it's a single layer, it has to be squamous.
Cuboidal epithelium.
Flattened cuboidal epithelium. Very good, Guru Shekhar. Yes. All right. So if you think that there is a flattened lining over here, you have to make up your mind. When you see a lining, now when we saw a lining over here on 1A, there was a lining and we called it a squamous epithelium. It's because it is an epithelial lining. Now whenever I see a lining, I have to decide what kind of lining it is. Okay? Do you realize that the word, we said epithelium. So the word thelium means lining. Are there any other linings which have thelium at the end? Shruti?
endothelium. Ma'am, endothelium.
Endothelium. Very good. Is it a lining?
Yes, ma'am.
Yes. Very good. It's a lining that is seen on the most innermost lining of the blood vessels. That's
Yes,
an endothelium. Is there any other thelium that you know of?
Ma'am, mesothelium.
Mesothelium. There you are. It's a lining, okay, which is lining the pleural and the peritoneal cavities. Excellent. So we have epithelium, we have endothelium, we have mesothelium. Okay. Now, whenever I see a lining, I have to figure out, is it endothelium, epithelium, or mesothelium? So come on now, Shruti, what is in case 1B? Epithelium, endothelium, or mesothelium?
It appears as endothelium.
It appears as endothelium.
Again,
In
it is not
1B, are you sure, Shruti?
no, ma'am.
Why are you calling it an endothelium?
Mesothelium. I'll go with mesothelium, ma'am.
You'll go with mesothelium. Acha, okay. Right. So Guru Shekhar thought it was an epithelium. You think it's a mesothelium. All right. And you don't see a lining in 1A. Is that right, Shruti?
Yes, ma'am.
All right.
Not for the cystic spaces, but the lining of the tongue, we can see, ma'am.
I can see. All right. Now can you see a lining to the cystic spaces or you can't in 1A? Is there a lining? You should have seen all this, no? When you looked at your cases. But you can certainly see something in 1B, right?
Yes, ma'am.
Yes or no?
Yes, ma'am.
Yeah. So what are you saying now? Is it mesothelium? Or is it epithelium? What? Anybody else? What about Ashwin? What do you think, Ashwin?
1B, it looks like an
1B looks like what?
epithelium into thrown papillary like projections.
So it's thrown into some, I don't know about papillary, but it is certainly not smooth. You know, the lining is sort of folded. Yes, so there are these little, sort of wavy kind of lining to this epithelium, to this these cysts, and you think it's an epithelium. Good. But now let me ask you, Ashwin, can you see a lining in case 1A? Or is there no lining at all? Now look, can you see? Come on, Ashwin, can you see a lining in 1A?
1A, it's an endothelial like lining.
So there is a lining. There's very much a lining, except that it is not epithelial. It is endothelial. So there is an endothelial lining to the cystic spaces in 1A, and there is an epithelial lining. Well, I think somebody might think it is a mesothelial lining that is thrown into little projections in 1B. They are both cystic spaces, but one is lined by an epithelium and the other one is lined by a endothelium, but both have got thelia. They are both thelia. Okay, so now you know what is the meaning of this word thelium. Thelium means a lining. Okay, so now Shruti, you want to tell me what is this? You have got cystic spaces. Can you encapsulate this into some into a one-liner as to what you're seeing in case 1A and what you're seeing in case 1B?
Ma'am, in case,
Yes, very good.
in case 1A, we can see mucosa with submucosa, which is
It's not submucosa, it's subepithelium.
subepithelium.
You see squamous epithelium. Yes,
with underlying subepithelium, which shows multiple cystic structures lined by endothelial cells.
very good.
And
Right. And what do you think is in those cystic spaces? It's pale eosinophilic. Yes, you just said pink, but it is actually pale eosinophilic. So you've got an endothelial lining and pale eosinophilic material there, and something is not there. So then you know that there's pale eosinophilic material, but what is not seen in these endothelial line spaces? Can you tell me, Shruti?
Ma'am,
What is not seen?
No
we
RBCs.
think from the lines of blood vessels, then we cannot see any RBCs inside.
So you don't see any RBC. So there again is part of your observation. You make observations that are positive and observations that are negative. So repeat again, what is it that you are seeing, Shruti, in this on the left-hand side in case 1A?
And we can see multiple cystic structures which are lined by the endothelium and not having RBCs inside them.
There are no RBCs. Although it is an endothelial lined space, there are no RBCs. And this is sitting in the subepithelium of the tongue. Yes, because the tongue is lined by squamous epithelium, and you can see clearly here that this epithelium is not proliferated at all. It is exactly the same number of layers as you would expect to see in the tongue. But this tongue is thrown into these papillary-like projections because of these. The space in the subepithelium is occupied by these endothelial line spaces in which there are no RBCs. Very good. Come on, Shruti, what are you seeing on the right-hand side? We saw on low power that this was demarcated from the pancreas, although it is said to be in the pancreas. Okay, but it is well demarcated from the pancreas. It's almost like it has a capsule. Okay, and
Again, ma'am, we can see multiple cystic spaces which are lined by the epithelium here.
okay, very good. And what is the lining? What the lining epithelium is what? I mean, how do you describe it?
It looks like cuboidal epithelium.
Very good. It is cuboidal. Anything else that you notice about it? It's not just cuboidal. You have to notice what the cells are like. I mean, there's nothing to notice in case 1A because it's absolutely flattened. There's nothing that you can see. But this is not flattened. You said it is cuboidal. So what is the character of those cuboidal cells?
Ma'am, they are thrown into some projections.
Yes, okay. They maybe you might want to call it micropapillary or something of that sort. But they have a character. No, what does each cell look like, Shruti? How do you describe a cell?
It is like with a round central nucleus,
Right. It's got a central nucleus. Very good. Then
with moderate cytoplasm, and it is
moderate amount of cytoplasm. All right. And what is the character of the cytoplasm? That's it. How cytoplasm and whether it's a central nucleus, that's not how we describe cells. What observations are you making on these cells? See, this is what I'm saying. As a student, and whether it's you are young or you're like me, unless we are making observations, we are not going to get further in to make a diagnosis. So what is the character of these cells?
they
What's
have
the
clear,
cytoplasm like? What color is the cytoplasm at least?
they have clear cytoplasm.
They have clear cytoplasm. Excellent. Most of them have got clear cytoplasm. You can see that. There is a clear cytoplasm and they're cuboidal. And yes, they are thrown into these little folds. There are some Roman bridges or whatever else you may wish to describe them as. But there is an epithelium which is composed of small clear cells. They're not large cells or anything. The cells are small, they're clear, and they have centrally placed nuclei. And the nuclei look very bland. Okay. All of these cells it's a monomorphic type of cell. There is no variation from one part of this lesion to the other. Yes, so there is no nuclear or cytoplasmic anisonucleosis or anisocytosis. Do you agree, Shruti?
No.
Very good. So now it should be very easy to make the diagnosis. So what do you think? Endothelial line spaces with no RBCs in them, in the tongue. And here you have epithelial line spaces, okay, with clear cytoplasm, small cells, all monomorphic, clear cytoplasm. Yeah, cuboidal in nature.
Case 1A, there can be lymphatic channels.
Lymphatic channels, very good, very good. And in the other?
Ma'am, they appear as
Right. It doesn't matter if you haven't reached the diagnosis. But for the audience in general, right, when you are looking at anything under low power, there are 5 questions that you have to ask yourself. And the first question is there any normal tissue or structure present? So, Shruti, is there any normal tissue or structure present?
ma'am, the epithelium looks normal.
Yes, so there is a structure, and that is the squamous mucosa of the anterior tongue. Yes. Is there any abnormality seen?
Yes, ma'am.
Okay, and what is that abnormality?
Ma'am, multiple cystic structures.
Yes.
In
The abnormality is present in the subepithelium.
Yes,
Is
ma'am.
there a pattern to this abnormality? And the answer is yes, there are dilated cystic spaces. And the 5th question you ask yourself is where should I direct my high power examination? Okay, very good. And you would want to do it to the lining of the cysts. We have done all this when we were discussing how to go about making observations. Okay, for case 1B, is there any normal structure present?
Yes, ma'am.
There is the pancreas. Is there any abnormality seen? And the answer is
Yes,
yes.
ma'am.
What is the relationship of the normal to the abnormal?
Well demarcated.
Yes, it's well demarcated from the pancreas. It's not intervening, it's not infiltrating, it's not indenting the pancreas or anything of the sort. It is well demarcated from the pancreas. Is there a pattern to this abnormality, Shruti?
Yes, ma'am. Multiple
What is
cystic
it?
spaces.
Dilated cystic spaces. And where should you look for your high power? That's the lining of the cyst. Okay. You know why we ask the first question? Is there any normal tissue or structure present? Why should we ask that question, Shruti?
Like if the pathology has completely replaced the normal organ.
All right. That's number one.
For the identification of
Exactly. It is to identify what you are seeing. All right. You may or may not be told in the request form the identity of it. Or worse still, the request form says that this is the liver and I'm seeing the pancreas. So then there is a problem, isn't there?
Yes,
so the first thing is not to ask yourself, what is the diagnosis? What am I seeing in this? It is to ask yourself, is there any normal tissue or structure present? Can I identify it? Is it what is stated in the request form? All right. Very good. Now, the second kind of schema that you require when you're making any diagnosis is to go or proceed in an algorithmic way. And really, what are we trying to find out? What is the lining of the cystic spaces? We did this, okay? We won't go into so much detail in the next, 3 or 4 cases, but this case is so important to, into as a standard case as to how to reach a diagnosis. All right. So, what is the lining of the cystic spaces in case number 1A? What is it? It's flattened epithelium, it's endothelium, or is it stroma? And we've already said that. What do you think it is?
endothelium.
Endothelium. Very good. Now we have to come to a diagnosis. And this is the schema that students should try and use. If you have any other schema, you have any other system of making a diagnosis, please use it. But I find this extremely important. Okay. The first question is it congenital or is it acquired? What do you think, Shruti?
I think it is acquired.
It is acquired. All right. Is it physiological or is it pathological?
Pathological.
Pathological. All right. Now tell me, is it neoplastic or is it non-neoplastic? Not. Tell me.
Neoplastic, it appears.
It appears neoplastic. How would you know whether it was neoplastic or non-neoplastic? Because these are cystic spaces, right? And you told me that they're lined by endothelium and there's no blood in it, so they must be lymphatics, right? So now, is this lymphangiectasia? Because that's what it is. Yes. Is it neoplastic or is it non-neoplastic? And the answer is that we can't tell, right? It's not easy to tell whether this lymphangiectasia is being caused by a blockage of a major lymph vessel or it's neoplastic. So whatever it is not malignant. You agree, Shruti? Yes, so it is benign, whether it is neoplastic or it is non-neoplastic. Now, the question of whether it's primary or secondary does not arise. So, what do you think is the diagnosis in this case? What diagnosis did you make?
I thought in the lines of lymphangioma, ma'am.
Lymphangioma. All right, very good. So, why did you have a lot of trouble in the beginning? And you said that there was no lining to this. You think lymphangiomas don't have a lining, Shruti? No. But it does have a lining, right? Okay, very good. Guru Shekhar, what's your diagnosis?
Lymphangioma.
Lymphangioma. Very good. Asma?
I also thought of lymphangioma.
Lymphangioma. Ashwin?
Lymphangioma.
And what about Ismail? Is Ismail there?
Yes, I'm there. Lymphangioma.
Lymphangioma. All right. All you guys are very good. Yes. And there is this very characteristic lymphangioma that occurs in the tongue, and it is called lymphangioma circumscriptum. Okay, but you get the idea of how one is supposed to make observations and then come to a reasonable diagnosis. All right. Now let's go to the other. What is the lining of the cystic spaces? Is it epithelium? Is it endothelium? Or is it stroma? We've already done that. What is it, Shruti?
Epithelium, ma'am.
Epithelium. Okay. So now tell me, is it congenital or acquired?
Acquired.
Very good. Is it pathological?
Yes.
Yes. Is it neoplastic or non-neoplastic?
Neoplastic, ma'am.
Neoplastic. Okay. Is it benign or malignant?
Benign.
It's benign. So what is it?
Some adenomatous lesion of pancreas.
Adenomatous lesion of the pancreas. Okay, good. Ismail, what did you think it was? It has got clear cells, cuboidal cells, low cuboidal cells. Ismail, what did you think?
Thinking of self-cystadenoma.
What did you think of, Ismail?
Cystadenoma.
Cystadenoma. Excellent. Very good. Ashwin?
It could be a microcystic serous cystadenoma.
Very good. Excellent. Guru Shekhar?
Microcystic serous cystadenoma.
All right. And what about you, Asma?
Serous cystadenoma.
Yes, it is a serous cystadenoma of the pancreas. All of you did very well. Okay. And it's a serous cystadenoma of the pancreas, and it is clear because it contains. What does it contain? What is the stain that we have done over here? Shruti? Yes, it is PS.
Yes,
And
ma'am.
what are these stains? These two stains that we have done? Is it one stain or two stains?
Ma'am, one stain, one is without diastasis and one is with diastasis.
All right. So we do it on the same slide, Shruti? Do we do it on the same slide? Or do we need two slides to do this?
On different slides, ma'am.
On different slides. Okay. So we did a PS here, and this PS showed up this magenta colored stuff, and we did a PS on the other slide, but after it, we had digested this with diastase. Okay. And this magenta stuff is no longer seen. So what does that mean, Shruti?
The diastase, it destroys the content inside the cells. That is.
So what is that content inside the cell?
Glycogen.
Glycogen, yes. And so when you have glycogen, you take one slide and you do the PS without digesting it with diastase. The second one you digest it with diastase and then do the PS, and you'll find that the glycogen has been digested and it no longer reacts with PS. All right. So this is a per-iodic acid Schiff with and without diastase. Okay. So now let's get to the next slide and the next case, and we'll have to go quicker. It's just that I wanted to spend some time on how do you actually make observations. Okay. And I'm glad that I hope that you now know what is an epithelium and what is a mucosa, and that you can't use these two things interchangeably. Very good. Now who wants to take case number 2? Asma, you want to take case number 2?
Case number 2.
Yes. Yeah. There's 2A and sorry, this should be 2A and 2B. It's I've mislabeled it. Come on.
Case 2A, male, 46-year-old, biopsy of a mass at the gastric fundus. And case 2B is male, 66-year-old, and biopsy of the nodular gastric mucosa.
All right. Everybody has paid attention to the thing. Both of them are in the stomach, right? Is there any difference between the two apart from the fact that they are in the similarity is it that they are in the stomach? Asma, is there any difference between the two histories?
I think it's a fundus.
Both are adults. One is 20 years younger than the other. Okay.
And in first, it is mentioned that it is from fundus, and I don't know from where is the nodular
So
gastric.
then that you can't tell the difference. But anybody notices something interesting, which histories are not just given to be read. Yeah, histories are given to be also interpreted. Anybody notices anything about this gastric lesions in A and B?
In B, it is of nodular nature, so
Yes.
it gives a well encapsulated mass and not.
Sorry, repeat that.
Ma'am, the nature of the lesion is given that is nodular in 2B case.
Yes, and
Uh,
so what does that mean? Nodular means what?
Protein.
Ma'am, it is not breaching.
That there are multiple discrete lesions in the gastric mucosa. Isn't that what it means? Yeah. So it's not one mass, but in case number 2A, there is one mass in the gastric fundus, whereas in 2 there are multiple discrete lesions in the gastric mucosa. Agreed, Asma?
Yes.
Yes. So they are obviously not similar on gross examination. Of course, we don't have the growth because we only got biopsies, but this is the nature of these two lesions. Okay, come on, Asma. I know that 2A is a little fuzzy, but we'll see it at a little higher part. But what do you want to tell me? You said that you did not know where in the gastric mucosa B was, right? So where is A and where is B in the gastric mucosa?
A look like body type of mucosa because the ratio of crypt and glands is 1:3 to me in this slide.
Okay,
Gland-
very
and
good. So it looks like
second-
body mucosa, yes.
And second slide, it looks like antrum kind of mucosa because they are 1:1. And I can see that mucosal ulceration at one place here.
Okay. You think that this is mucosal ulceration, right? Where my arrow is? Yes?
Yeah.
Why do you think it's an ulcer?
Because there's discontinuity of mucosa, and I think these are inflammation.
Yes, so there's inflammation, I agree. But you don't feel that this could just be an artifact of cutting? Huh? Otherwise, everything looks pretty good, no? So it could just be an artifact of cutting. We don't know for certain that is an ulcer. All right, I grant you. It may be an ulcer. I cannot tell you for certain that it is or it isn't. Yes. Anybody wants to ask any question or otherwise? Okay. So now you can see that. Oh, you see the ulcer. Anything else you noticed? Asma, at this power?
Yeah, I feel that this area is normal, and there's something going on here.
Do you want to ask for annotation so that we all know which area you're talking about?
Yeah.
Yeah, please. Excellent. Now come on. Annotate and tell me which area you are talking about.
This part is normal, and there's something going on here.
Something is going on there. Okay. This part is normal. Okay. What about in 2A?
2A, I can't get it. Well, I think this is normal glands, and
Good.
other than that, I cannot make out much.
You cannot make out. All right. Very good. Asma, I want you to look at something that I am going to mark. Do you put something here? What is this?
I think, yeah.
You can't make out? Anybody can see what there is over there?
I'm clearly not
Like normal?
Just tell metaplasia.
Goblet
Who said
cells.
that? Who said that? Shaker. Excellent. So this is abnormal with respect to all the rest of this gastric epithelium. You can see that they are all. She's right that this is antral mucosa because in antral mucosa you see the long foveolar bits and then they branch at the end, which is not seen in the other, the foveoli in the other parts of the stomach. But you see one foveolar epithelium there, which is not looking like the neutral mucin that you're seeing in all the rest. And so what are you seeing over here now? You're seeing goblet cells. We'll see whether we can see that at any other higher power. Okay. So now Asma, on the left side and on the right side?
Left side, for me, it is normal mucosa. These are
Absolutely normal. You're very right, Asma. Yes. And on the right?
on the right, these are goblet cells. I can see, so it is intestinal metaplasia. And
Yes, those are goblet cells. Okay. Anything else you see?
Inflammatory cells infiltrate.
cells.
Inflammatory cells. Yes. What inflammatory cells are you seeing?
Neutrophils.
Neutrophils. Something that's looking so orange. What are they?
Eosinophils.
Eosinophils. Yes. Very good. But what's to the right of this section? What is to the right of this section?
Islet
What's
of
this
cells.
bit?
Are these
What is to the right of this section? What do you see here?
They are island of the cells which are not making lumen, basically.
Okay. Yes. What do you see? See here. This is. What do you see? Asma? What do you see?
They are
This doesn't look like the pits, the foveolar epithelium, and it doesn't look like gastric antral glands, which would be mucin secreting. Yes, somebody was saying something. What were you saying? You see?
correct.
So there are nests. There
Nests
are
of cells.
nests of cells. You see these nests of cells? Each one of them is a nest. Yes. Here you may see some nests, or you also see cords. You see of the same type of cells. And what are those cells? They're monomorphic. They are small. They have very dense nuclei. You can't see into the nuclei over here. Yes. And what? Yes. So they look bland and they are dense. Okay. And they are in this nested kind of pattern. So you have intestinal metaplasia. Yes. Oh, come on. Let's go to the next. Come on. Yes. So now you can see that much better. Come on, Asma. What's on the left?
left. I can see here on the right side there is normal gastric glands, and then underneath that I can see muscularized mucosae, and
Yes, excellent.
And beneath
you
that
see
I can
on
see-
one side, you see normal gastric glands, very good. And then you see the muscularis mucosae, yes.
and then below muscularized mucosae in submucosa I can see the tumor cells, which are arranged in sheets,
Hmm.
and a moderate amount of cytoplasm,
Very good.
eosinophilic, and round to nucleus
Yes,
with inconspicuous nucleoli,
yes.
moderate pleomorphism. There's
Moderate pleomorphism. All of you should stop using this word pleomorphic. Pleomorphic means marked variation in size, shape, and tinctorial properties, etc. Don't use the word pleomorphism. Please say that there is mild or moderate anisonucleosis or anisocytosis or whatever. They are not pleomorphic cells at all. The moment you start using words like pleomorphic, it's a very kind of a bizarre kind of thought is often enters into the heads of somebody who is listening to you. This is not bizarre. This is just, in fact, it's relatively monomorphic with some anisonucleosis, as I would put it. But what is important is what you said, that you have the gastric mucosa on one side, then you have the muscularis mucosae, and on the other side you have this tumor, which is in sheets. Yes, you want to describe the cells a little bit better. They're eosinophilic. What is the appearance of the cells? What's the pattern apart from the fact that they are in sheets? What do they look like to you? Are they spindly? Do they look epithelioid? Do they look mesenchymal? They look epithelioid.
epithelioid.
Yeah, that is a very important thing to be able to notice. Does this look epithelioid? Does it look mesenchymal? Does it look round cell? Does it look hematolymphoid? Just like we said, when you have a lining, is it endothelium? Is it mesothelium? Is it epithelium? Similarly, when you see a tumor, you look at that tumor and you ask yourself, does this tumor look, is the arrangement of the cells, they may be in sheets, but do they look epithelioid? Do they look mesenchymal? Do they look a round cell? Do they look like a hematolymphoid neoplasm? So which one will you pick, Asma?
I'll pick epithelioid.
Good. Anybody else wants to pick anything else? Shruti?
Epithelioid only, ma'am.
Epithelioid. Everybody says epithelioid. Ismail, what do you think? Epithelioid. Very good. All right. Now, Asma, on the right-hand side.
Right hand side, I can see some glands, some normal glands with some abnormal tumor cells, some in nests with moderate cytoplasm, and nucleus are monomorphic with inconspicuous nucleoli.
Exactly. So they are dense, right? You can't see nuclei, and obviously because this nucleus is not an open-faced or vesicular nucleus. Excellent. So you've done that description very well, Asma. Now here, you can see those cells better on both sides. Yes. And you can see here, there is in the bottom right-hand corner, you can see the goblet cells. You can see the goblet cells in the top right-hand corner. So there is intestinal metaplasia. Now you can describe the cells that you are seeing. What are the cells like now? Describe them. Do you still feel that these are epithelioid? Is there a difference in the nuclear characteristics of the cells on the left side versus the right side? Or are they the same?
Then
Ashwin, you want to say? Come on, Ashwin.
It's
Sorry, I could hear you, Ashwin.
it's epithelial.
Yeah, so both of these show you an epithelioid pattern. Okay, I don't know if it's epithelial, but they're certainly epithelioid. And how do we know, Asma, or why did all of you say that these are epithelioid? What is the character of these cells and the way that they are arranged that made you say that these are epithelioid? We can't just say epithelioid, right? We have to have something that, some characteristic that we recognize that says that these are epithelioid. So what is it, Asma?
I think they are not well separated. I don't know.
Not well separated. Yes. What do you mean by not well separated? You're on the right track, Asma. What do you mean by not well separated? It means that they are.
Cohesive.
Sorry, somebody was saying
Cohesive.
something. That they are
Cohesive.
cohesive. Very good. Who said that, Shruti?
Yes.
Yes. So they are cohesive. Now that is one of the main features of what we want to call, characteristic of what we want to call epithelioid. They are cohesive, and you can see that in both of these pictures, the cells are cohesive. You can't see a kind of a space between one cell and the next. All right. Anything else that is a characteristic of epithelioid? Cohesion is one of the main characteristics. Anything else? Anything else? Come on, it should have some amount of cytoplasm, right? You don't get, think about it. Which epithelia are there which show you no cytoplasm at all? No. So the cytoplasm has to be relatively moderate. In other words, it should be prominent. You can't have an epithelioid character unless you see a certain amount of cytoplasm. Do you agree, Asma?
Yes.
Yes. So it should be cohesive. There should be cytoplasm. There may or may not be very well-defined cytoplasmic boundaries. Now look carefully. On the left-hand side, you don't see good cytoplasmic boundaries, do you? No, they're not seen. But on the right-hand side, you can.
Yeah.
Do you appreciate that or not?
Yes.
Yes. And yet both of them, we feel, have an epithelioid character because there are two important characteristics of what we refer to as an epithelioid appearance, and that is cohesion
And
and
cytoplasm.
yes, a certain amount of cytoplasm. So that's how we say that these lesions have an epithelioid character. There are very clear cytoplasmic boundaries on the right, but there are very, very ill-defined or undefined. It's almost in many places, it's like a syncytium. I can't see one cell. I can see it merging into the other cell. All right. So very good. Now, anybody wants to, Asma, sorry, you're discussing it. What do you think?
I think I will tell about second case first.
All right.
Case, not too much pleomorphism. Sorry for the pleomorphism. Not so much anisonucleosis and anisocytosis.
And
And
it's monomorphic, young lady.
monomorphic and the
Yes.
pattern of arrangement in nests. So for me, it is neuroendocrine tumor and no conspicuous nuclei.
Excellent. Neuroendocrine tumor. All right. What about on the left?
On the left, I thought it was submucosa and mucosa is normal, so I thought of epithelial cyst.
Wonderful. Okay. Anybody wants to disagree with Asma? What did you think, Guru Shekhar?
Same.
Same. Okay. What about Ismail? Are you there, Ismail?
Yes, ma'am.
So what's the case 2A for you?
Looking at the nature of those cells, the questiveness, in some areas, those cells appear elongated with an impact on the surface mucosa. Could it be gist?
It could be a gist. Very good. And what about 2B? What do you think about 2B? Ismail? Maybe he can't hear me. All right, Ashwin?
Ma'am, first 2A, since the solution is beneath submucosa, it would be a gist, ma'am.
Right. And to be
And 2B, the nest pattern and all favors a neuroendocrine mucosa.
neuroendocrine tumor. Shruti?
Ma'am, in case 2A, there are some mesenchymal looking cells also in between the cells. Can we,
Okay.
there's some flattened spindly cells in between.
So,
Like, can it be also considered in epithelioid morphology of cells, ma'am?
yes, of course, it's still cohesive. So your very, very acute observation that there are spindly cells over here. Yes, there are. There are some spindly cells. There are some cells with oval nuclei, etc. So what you are asking, Shruti, is that if you have spindle cells, can you have an epithelioid character? Yeah, you can still have an epithelioid character. Depends upon how spindly they are. These are more oval than they are spindly. But the fact that you saw spindle cells in this otherwise epithelioid-looking tumor makes you say that this cannot be epithelial. It is going to be something that is non-epithelial but has an epithelioid character. All right, that is the interpretation of my observation. The observation is that it is epithelioid, and like Shruti said, there are oval cells and there are some spindle cells. So this is highly unlikely to be, and for the other reasons that you gave, and that is it is not in the mucosa, it is deep to the muscularis mucosae, that this lesion, which looks epithelioid, is unlikely to be epithelial, much more likely to be something that is arising in or showing differentiation to something that is of mesenchymal origin but is looking epithelioid. Okay, so we now let us do our observations, and we know our 5 questions that have to be answered. So the first question is there any normal tissue? Yes, there's gastric body mucosa, there's gastric antral mucosa. The epithelium is essentially normal here. Here there is intestinal metaplasia. This abnormality is in the submucosa, which all of you have pointed out, and full marks for that. Here the abnormality is in the lamina propria. It is not in the submucosa. Yes. So can I just ask you now, since we did all this big thing about mucosa in the first case, Guru Shekhar, the lamina propria is what? Is part of what? Part of the stomach. Guru Shekhar, are you there? Guru Shekhar, you disappeared?
Mucosa, ma'am.
It's part of the mucosa, exactly. So there is the epithelium, there is the lamina propria, and the last part of that of the mucosa is the muscularis mucosae. Very good, Guru Shekhar. And I hope everybody has understood now that you have an epithelium, you have a lamina propria in the case of the stomach, in the case of the small and large intestines, that there are these 3 parts that make up the mucosa. Okay. Now, here you have sheets of epithelioid cells. On this side, you have nests of epithelioid cells. Okay. And then the description, as you have all done, you have made a very good description that the cells have a moderate amount of light eosinophilic cytoplasm, oval or irregular, bland, pale, vesicular nuclei, and there were no mitoses. And similarly here, except that the nuclei were dense. Okay, you couldn't see much in of what was happening or the morphology of the nuclei. Here in 2A, there was no inflammatory response, and there was an inflammatory response in the lamina propria. All of you pointed it out. You said that there were neutrophils and there were eosinophils. There were a few plasma cells and lymphocytes. So with this, they look so much alike. They have an epithelioid. They're both in the stomach. They have an epithelioid morphology, and yet they are distinct entities. Okay. So, this is just for fun. I used to go to have my teeth straightened when I was a kid. And there was this lovely thing in the dentist, my orthodontist waiting room, where he used to discourage people from chewing gum. Okay, so he said a gum chewing kid and a cut chewing cow. They are the same, yet different somehow. Ah, yes, I get it now. It's the intelligent look on the face of the cow. In other words, that if you're chewing gum, you must be an idiot. Okay, so now let's get on with this. So we know what were the similarities, what are the differences, okay? And what are the differences? And that's why I said it is very important to note everything that you are told. Sorry. You have a mass lesion on the one hand here, you have sheets, these are intermediate sized cells, there's anisocytosis, pale vesicular nuclei, and normal body mucosa, okay? And we said all that here. The main thing to note is there is nodularity in the stomach and there are nests, okay? So what are your thoughts? Here there is only one thought, and everybody had only one thought, and that is neuroendocrine hypoplasia or neuroendocrine neoplasia. But on this side, people might have other thoughts. Could it be a neuroendocrine tumor? Because you can also get them in the submucosa, carcinoma, unlikely, melanoma, they don't look like that at all. Some soft tissue tumor or a lymphoma. And I think these are just unnecessary differential diagnoses. Yeah, maybe neuroendocrine tumor and soft tissue tumor are about the only ones that you need to take into consideration. So here now, we do some immunohistochemistry. This is cytokeratin in case 2A. Now we're looking at only 2A. These are not 2A and 2B. Right? So come on now, Asma, you are able to just interpret this immunohistochemistry.
First slide in cytokeratin, cytoplasmic staining in the mucosa.
Very good. And the mucosa looks absolutely normal, right?
Normal, yeah.
Yes.
I
Fine.
suggested the cells, the tumors beneath it are not the epithelial because they are not
Very
stained.
good. Yeah, absolutely. So they are epithelioid, but they are not epithelial. And you know the difference between epithelial and epithelioid, right? What's the difference? What's the difference, Asma? What's the difference between epithelial and epithelioid?
Epithelioid just look like epithelium, but it can be derived from other sites other than epithelium. Basically, as you said, induced mesenchymal origin tumors can also take look of epithelioid.
Very good. Excellent. All right. Now, what about the other immunostain?
Other smooth muscle actin.
Yes, it's smooth muscle actin, it's SMA. Very good. So what do you want to say about what you're seeing over here?
I think it is staining the muscle in between the tumor cells.
Sorry, what is there anything that's positive?
I think tumor cells are negative.
All right, very good. Asma,
and the brown color.
What is stained?
Yeah, it's vessels.
Oh, of course, these are the vessels. So this is the smooth muscle in the vessel walls that have stained. So in both cases, what you're getting is a negative stain, but you know that the stain has worked. How do you know that the stain has worked, Shruti?
Internal control.
Because we have an internal control.
Yes.
That's excellent. Okay. Next, come on, Asma.
Tumor cells are negative for S100.
Right. What's the internal control?
Internal control as hundred. I think they have 5.
What is that brown stuff that you're seeing? That is the internal control for S100 protein. Anybody? Shruti? What is it?
My
Anybody? What is this brown thing? You see, no, that they have processes, no? So there are dendritic cells in all tissues, and these must be interdigitating dendritic cells. The moment you see them, see they have processes. All of these have got processes, and they are dendritic cells that you see. All right. What about Desmond?
Desmin, tumor negative for Desmin, and internal control.
Positive. See, you see the smooth muscle wall of the vessel is positive. Yes. So every time you are interpreting a control or interpreting a stain, you must make certain that you have got an internal control. Now, what do you see now, Asma?
CD34. It is membranous.
Staining of CD34. Yes.
Membranous staining of CD34, and right side c-kit. Also, I think it's cytoplasmic.
Well, there is. You can see c-kit. No, what is c-kit?
Tyrosine kinase receptor membrane.
Yeah. So it is CD117, right?
It's membranous.
Yeah, so you can see it's a beautiful stain, and what do you see in both these apart from that, the fact that the tumor is CD34 positive and it is also CD117 positive? Is there anything else that you notice, Asma?
CD34.
Anybody? What is it that you notice, and which we should all notice? Yes,
the spread of it is well demarcated and it is not
it's well demarcated. No, I'm talking about the stain. What do you notice?
membranous.
Anybody? What is that? What did you see a whole lot of negative things? over there? So
Yeah.
just as we noticed that there were a positive internal control, we also have to look at negative internal control. Okay, so what is negative should be negative, otherwise your stain has not worked well. It is just stained a whole lot of things which it should not be staining. Do you understand? So yes, here you have CD34. You will notice that CD34 has got an internal control, which is, you see the blood vessel lining?
Yeah.
The endothelium is positive, so that is positive. Over here, you should be able to see mast cells, and you can see a few mast cells if you notice in the top right-hand corner over here. Can you see the mast cells? If you can see the mast cells, let me try and annotate and show you where the mast cells are sitting. Here they are. You see those little brown dots over there? Those are the mast cells. So the mast cells are positive. So that's the positive internal control for CD117 or c-kit. But there is a huge negative control. The glands are all negative. You see all these inflammatory cells, apart from the mast cells, are negative. And here too, you see the glands are negative, but you see the CD34 in the endothelial cells. So never just interpret any stain, whether it happens to be an immunostain or it is a stain as simple as mucin, without looking for internal controls if they are there. Okay. Otherwise, you have to have an external control. You have no other. So what is the diagnosis in 2A? All of you were spot on. This is an epithelioid gastrointestinal stromal tumor. So all of you have done very well. Kani, is there anything in the chat box that needs to be addressed?
How there was a question how to differentiate between congenital and acquired. It was related to the previous case actually.
Right. We will take that in due course. How to determine whether something is congenital or acquired. All right, we'll do that. All right, here comes case 2B. Now, Asma, will you answer this question? Is this stained for cytokeratin? Yes or no?
It is stained, but there must be some.
This is an immunostain. You can see that, no, Asma? Right. Is it stained for cytokeratin? Yes or no?
Yes.
What people in the chat box are also seeing. Yes, Asma?
Yes.
Yes, okay. According to you, yes. Let us ask all your colleagues. Ismail, is this stained for cytokeratin? Ismail?
Yes, ma'am.
It is stained for cytokeratin. All right.
Yes,
Let's
ma'am.
ask Ashwin. Is this stained for cytokeratin?
Normally,
Yes or no?
control is not negative.
Sorry, control. What are you saying?
It's negative.
Is this immunostain in these two pictures? Is this immunostain cytokeratin, Ashwin?
Yes, ma'am. It's positive, ma'am. Yes.
Okay. So you think it is the stain is for cytokeratin? All right, Shruti.
I think it is focally positive and not diffusely positive.
It is. But do you think that this stain is for cytokeratin? Yes or no? I don't
No.
want to know whether it's focally positive or diffusely positive. What?
No, ma'am. I don't think
So you are saying no. Okay. Now comes Guru Shekhar.
No, ma'am.
No, ma'am. All right. We have the two people who are saying no. What are they saying in the chat box, Kani? Nobody said anything in the chat box? Never mind. Okay. Now, Guru Shekhar and Shruti, will you say why you say that this is not cytokeratin stain?
Ma'am, if it was cytokeratin, then it should have stained like all the components and not just
What components are you talking about, Shruti?
the epithelial components.
The epithelial components. It should have stained all these alveoli and glands, right? What about you, Guru Shekhar? What? Why did you say no?
Yeah, ma'am. You should stay in all the epithelial.
Exactly. So, Asma and Ismail and Ashwin, do you get the point that this cannot be a cytokeratin stain? Because if it was cytokeratin, what should it have stained? It should have stained all of this stuff, right? But it has only stained some of it. So what is it? What do you think the stain is? Come on, Asma. What is it stained?
In the attendees have answered it is synaptophysin progranin.
Yes, it is a neuroendocrine marker. It is not cytokeratin because it has stained, as you see over here, it has stained the tumor cells, which are in nests. So all this has been stained, yes. And individual neuroendocrine cells in the foveoli have also been stained. There you are, each of these. And of course, you have some neuroendocrine hypoplasia as well. That's why you're seeing these little nests. But all the little neuroendocrine cells, and you know that there are neuroendocrine cells, right? In the gastric epithelium. Are you aware of that, Salma? Asma?
Yes,
Sorry, I'm calling Salma. Yeah, so what are those neuroendocrine cells?
Basically, you want
Which are the neuroendocrine cells that you see in normal gastric mucosa?
Enterochromatin.
Enterochromaffin-like cells, not enterochromaffin cells. Enterochromaffin cells are seen in the small bowel. You get ECL cells, enterochromaffin-like cells. What other cells do you get? ECL cells, yes. What else? gastrin. So the gastrin secreting cells, yes, and then you have somatostatin secreting cells, because there is a cycle that goes gastrin, which stimulates the ECL cells, yes, and when there is somatostatin is the negative feedback for gastrin. So you have at least 3 types of cells, but there are many more now. You can go and look it up. There is ghrelin secreting cells. There are so many other endocrine cells, and you know that those who do this bariatric surgery are actually using the loss of a part of the stomach, because that's what they do. They take off a part of the stomach to control a whole lot of your physiological hormones, and that's why patients also become, if they're diabetic before bariatric surgery, their diabetes disappears, because there are so many different neuroendocrine cells in the stomach. So the answer to this question is no. This happens to be chromogranin, but it could as well have been synaptophysin. Okay, do you understand this now, Asma and Ismail? And yeah, good, very good, Shruti and Guru Shekhar. All right, here you have synaptophysin and chromogranin. You cannot tell one from the other if you are using the same reporter molecule. Now, what is this reporter molecule that we are using, Asma? For immunohistochemistry, we use a reporter molecule, and that reporter molecule gives diaminobenzidine. Yes, diaminobenzidine is the substrate on which what enzyme acts on diaminobenzidine to get a brown coloration?
Yes, I don't know.
Huh?
I don't know about the enzyme.
You don't know about the enzyme, then how do you do immunohistochemistry, Asma? It's peroxidase, right? Yeah, and that's what, yes, that is what acts on DAB, so that you get a brown color, because the substrate then acts, the enzyme acts on the substrate, and you get a reaction which leads to a chromogen being formed, and this chromogen is this brown color. All right, very good. You can see what we call neuroendocrine hyperplasia, also known as microcarcinoidosis. Okay, that is present within it. You have the main neuroendocrine tumor, and you also have this microcarcinoidosis. Okay, so what is the diagnosis in this case? It's not just neuroendocrine tumor, it is atrophic gastritis with incomplete intestinal metaplasia, neuroendocrine hyperplasia, microcarcinoidosis, and a type 1 gastric carcinoid. Now, I cannot tell you about type 1 and type 2 and type 3 gastric carcinoids, but those of you who are interested should go and look at what are these different types of gastric carcinoid, and which of them are absolutely almost benign, nothing happens with these gastric carcinoids, and which have got a tendency to metastasis. Very good. All right, so now who's going to take case number 3? Ashwin?
Yes, ma'am.
Very good, come on.
Case 3A, 30-year-old female with excision of a painful 3 centimeter mass in the supraclavicular fossa.
Excellent.
3B,
Yes, we lost you, Ashwin.
3B, 8-year-old male, recurrent cutaneous and subcutaneous swelling over the left knee. A bleeding lesion was accessed from the same site 8 months before the present time.
Very good, Ashwin. All right, good. Come on.
3A shows a well circumscribed neoplasm.
Okay, excellent. Very good, Ashwin, come on.
3,
Finish with 3A, then you can go to 3B, or if anyway you are
also
looking at it as
cystic spaces filled with RBCs.
No, Ashwin, we can't hear you. Your network is unstable. Maybe you can do the next one. Guru Shekhar, your network is stable. Come on. Who's this now? Farheen, I cannot approve your annotation request. Okay. Yeah, come on, Guru Shekhar, we'll give Ashwin the next one.
It's well demarcated, well capsulated, and it shows coding inflammatory cells infiltrate and RBCs.
Guru Shekhar, I can't hear you now. Is your network is also not very good. All right, Ismail, come on, you try. Ismail, can you hear me?
Very well, ma'am.
Ismail, have you? Come on. Tell us about 3A. Describe it.
Yes, the 3A is well circumscribed lesions
Well circumscribed, yes.
comprising of this
What is
small
it that is common between the two? Let's just say that, because this is Tweedledum and Tweedledee. What is common between the two?
And capsule,
All right. Somebody thinks it's a capsule. Well, here there is a capsule. Yes,
The
I
space
can see that there is a capsule here. Asma, you've also got something has happened to your. Here, we're not sure if there is a capsule or there is no capsule, but there is some. It seems to be reasonably well circumscribed. All right. Okay. And what is common between the two?
the
That
space
there is a solid tumor, yes, with spaces, yes, with irregular spaces. See, you can very clearly see that there are these spaces. You can see them there, very irregular. They are interdigitating here and there with one another. So you have irregular spaces there. You have irregular spaces here, yes. And what do you see here? That the irregular spaces have hemorrhage, or you call RBCs in them. Maybe there is a little bit over here. I don't know, but here on the right hand side, very clearly you see that there are irregular spaces which are filled with blood. Okay, and both of them are solid, cellular, but in the center you can see spaces. Now you look at this again, and once again you see how similar they are. One looks a little more blue and the other looks a little pink. Yeah, Ashwin, have you got a better connection now?
Yes, ma'am.
Ashwin?
Yes, ma'am. Both these lesions
So come on.
showing a cystic
You
space
see
with
the similarities, yes.
both the lesions
Very
show a
good
cystic
similarities,
space
right? Spaces.
filled with the RBC, ma'am, or hemorrhagic cystic spaces.
Exactly. All right. And otherwise, they seem to be cellular. Excellent. Now let us see. What do you see on the left hand side?
On the left hand side, the tumor is seen a perivascular arrangement.
The tumor is seen to have a perivascular arrangement. What does that mean? There are vessels inside the tumor. That doesn't make it a perivascular arrangement. What is the meaning of a perivascular arrangement, Ashwin?
Seems around the vessel.
You really think that this tumor is around the vessels? Why do you say that they are around the vessels? Because you see this?
Yes, ma'am.
Because you see something like this? No, this is a tumor, and in the tumor you have vessels, and there's something interesting about these vessels. Come on, what is interesting about these vessels?
Tagon type.
And it's not just there.
Yeah.
Even the smaller vessels are showing you a similar appearance. The big vessels and the small vessels. Come on, Ashwin. you should be able to tell me what is special about these vessels. Look at them. Thick-walled, hyalinized, thick-walled blood vessels. Very good, Ashwin. Does everybody agree?
Yes.
Yes, there are hyalinized, thick-walled vessels. Now notice everywhere there's a whole group of, let me go back. Yeah, there's a whole group of vessels seen, and all these vessels have got a hyalinized wall. Excellent. What else do you want to say about this, the cells, Ashwin?
Cells are epithelial to spindle with abundant cytoplasm.
Okay, they have abundant cytoplasm. They are largely spindle. Now, would you like to tell me what arrangement? We can see it at the higher power, but you can see it here too. What arrangement is this? Can you see this arrangement? What is this arrangement? See all the nuclei going in this arrangement. What is that arrangement? Ashwin? That is not a palisade. Anybody, what is that arrangement?
Story form pattern.
Story form? No, it is not. You see all the nuclei like this. Okay, here they're all curving, but all the nuclei are going parallel to one another in a curved fashion.
Fascicle.
That is a fascicle. Yes, it is a fascicle. Very good. But don't you see anything else? Don't you see that there are areas that are cellular and other areas that are not cellular? Yes, which have these gaps. You see these little clear areas within these. So you have cellular and you have non-cellular areas and thick-walled vessels, and you have spindle cells. In this place, at least, you can see it in a fascicle. Now, what about in 3B? You can't see anything very much over here, except that you're seeing this irregular spaces that have got blood in them. Now what can you see? On the left-hand side?
Rear shows arrangement for segments.
Yes, there are fascicles. You can see that, but you can see something else as well. They're just not fascicles. Fascicles are cells which grow or sort of are bundles. The fascicles are made of bundles in which the cells have to be spindle. You cannot get a fascicle in which you don't have a spindle cell, okay? Or you must have elongated cells, and the elongated cells that you see over here are spindly. They are all running in the same direction, parallel to the direction in which the bundle is growing. Can you see that? This is, let me just show you this. They are all in one direction. Can you see all the cells, the spindle cells with their spindly nuclei are all growing, are all running in one thing, and that bundle is called a fascicle, okay? But I can see something else here.
Some alternate areas of hypocellular and hypercellular.
Hypercellular areas, very good. But what do you see somewhere here, for instance? Can you see the nuclei here? And what do you see at the nuclei here? They're all parallel, but they are. What's the difference between the fascicle and what you are seeing here?
It's like a palisade.
It's a palisade, but what's the difference between a palisade and a fascicle? Come on, Ashwin. They're parallel. This is also parallel. Ismail, what's the difference? I told you, this is what.
Segments will be
What is this arrow demarcating? What is this arrow
it goes in the
demarcating?
same direction.
So the direction in which the bundle is running. Here, what is the direction? So a palisade is parallelly placed elongated cells, nuclei, whatever, but they are perpendicular to the direction in which that bundle is running. Do you understand the difference now, Ashwin, between a fascicle and a palisade? All right, good. Okay, excellent. Ismail, do you understand? Excellent. All right, good. So now you can see this. What do you see here? You see a cellularity, right? And this cellularity is densest around those spaces in which there is hemorrhage. All right, now let's see what that cellularity looks like at higher power. Same thing, spindle cells on both sides. And you see this also has got some ill-formed fascicles. I'm sure all of you can see those ill-formed fascicles. Can you see that, Ashwin?
No.
Yes. Can you ask for annotation and show me where those ill-formed fascicles are? Very good. Now show me, where are those ill-formed fascicles? Pick any color you want, Ashwin. Are you able to do it? You started? You're talking about on 3A. On 3A, here there are no fascicles. What you have marked in green are just sheets. Okay, they may be fascicles if these fascicles are fascicles, as I told you, Ashwin, have to be formed with elongated cells. Can you show me elongated cells here? You can't see elongated cells, you can't see elongated nuclei. No, these are sheets. They may be fascicles if the fascicles have been cut obliquely, but I cannot obliquely or transversely, but that I cannot say looking at this. But look at 3B. At 3B, here you are. Here are the fascicles. Can you see them? All of them, the nuclei are long. Yes, exactly. That's where you're seeing the fascicles. So there are spindle cells on the right and there are spindle cells on the left, but here on the left you are seeing sheets, which you cannot make out if there are fascicles or no fascicles, but we did see fascicles in the previous section. And of course, you see these thick-walled blood vessels. Excellent. Now what do you see over here? You can't make out, no, that there are fascicles because these are at right angles. But here you can make out some fascicles. But let's see, go a little higher. Now you tell me what kind of cells there are on the right-hand side. Tell me about 3B.
Right-hand side.
What's going on the right-hand side? And tell me, what is the look on the left-hand side and what is the look? And what will you say are the differences? What are the differences? What are the differences?
Left-hand side looks to be in a
Almost
sheets.
monomorphic, right? Monomorphic in sheets, except that you see those ionized blood vessels. Over here, there is a variation, no? Like somebody said that there is a mild pleomorphism of that scene. I hate to use that term, but you're seeing some variation in nuclear size, nuclear shape.
Anisonucleosis.
Yes, absolutely. And there is anisonucleosis, both the shape and the size of these nuclei vary. You see the fascicle here now. Very good. And here it seems almost round, but that's because the fascicles are probably cut at right angles. Okay. Now you see it at even higher power. Here you see spindle cells on the left side, and you see some spindle, some irregular looking nuclei. Some of the cells are even showing you some irregularity. The cytoplasm of these cells are actually irregular. You can see, if I can show it to you, maybe I should take a thinner thing. All right. Let me see. Can you see that there are some, I'm drawing a line because they're so slim. Can you see that these cells have got little processes? Yeah, the cells on that side have processes. Here there are only two processes at each pole of the cell. Here there are multiple processes to the cell. So you've got a cellular shape that is different. On the left hand side, the shape is spindly, sometimes cut at right angles, and over here the shape of the cell is irregular, and that of the nuclei are irregular. Okay, now I don't need to annotate. Get rid of this annotation. Okay, and at the periphery of 3B, you see that there is an inflammatory infiltrate which has got lymphoid follicles. Yes. So now, what are we dealing with? I don't expect you to get the diagnosis at all, okay? But we have to make an attempt. You see this now? This is 3A. And this, at least, you should be able to make a diagnosis of. What is your diagnosis, Ashwin? What was your diagnosis on 3A? Come on, you want to try? Congenital or acquired? Yeah.
Acquired, ma'am.
Acquired. Very good. Physiological or pathological?
Pathological.
Pathological. Okay. Neoplastic or non-neoplastic?
Neoplastic one.
Neoplastic. Is it benign or malignant? What?
Malignant one.
You think it is malignant. Excellent. Now let us ask all your colleagues. Ismail, you think it's benign or malignant?
It's benign.
It's benign. Okay. Asma?
Benign. Benign.
Benign. Shruti?
I think it is benign.
You think it's benign. Gurushekar?
I think it's malignant.
You think it's malignant. All right. So 2 people think it's malignant. 3 people think it's benign. How do you make that distinction? Oh, it's a question. All right. So you have to look at the tumor. All right. So let us put up what are the characteristics of the tumor. Number 1. Come on, Ashwin. What was it? Circumscribed. Right. Then we were told it was a painful mass in the neck. Yes. And it has fascicles of spindle cells. You have cellular and loose arrangements. You had thick-walled hyalinized blood vessels, and you had foci of hemorrhage. Now you tell me, Ashwin and Gurushekar, why did you call it malignant? Did you see mitoses? Did you see a lot of pleomorphism? Why? Why did you call this circumscribed lesion with both cellular and loose arrangements? Why did you call it malignant?
I'll go with benign.
Now who says this? Go with benign. Gurushekar, you changed your mind.
Yes, ma'am.
Okay. Are you going to change your mind, Ashwin?
Benign.
Benign. So now that everybody has come on benign, what is it? Come on, Ashwin, you get the first shot. What is it?
Can it be schwannoma?
It is there
Schwannoma.
in the observations. Yes.
Could it be schwannoma, ma'am?
Could it be? It
When
is.
the hemorrhagic
It
changes,
is.
so it should
Yes,
be
it
ancient
is a
schwannoma.
schwannoma with degenerative changes. And this was as easy as pie if you only sat down and made a list of what your observations were. Was it difficult, Ashwin? What was it difficult? The answer has to be what, Ashwin? Was it difficult?
No, ma'am.
No. Okay, but it became difficult. Why? Because we did not list our observations in a systematic way, and we did not use some kind of algorithm to reach this diagnosis. Very good. So this is a schwannoma with degenerative changes. Antony A, Antony B, thick-walled blood vessels, fascicles, spindle cells. Okay, case 3B. All right, who wants to take this case? You see all of the features that I have showed you over here. And the features are what? That this is a spindle cell tumor, which is showing you this irregular areas of, right in the middle of the tumor, there are irregular areas that are spaces, okay, basically, in which there is blood. And the periphery of this tumor, so centrally spaces filled with blood, and peripherally you have lymphoid follicles. And this is a spindle cell tumor in which you get a degree of irregularity in the cytoplasm and in the nucleus. Anybody, Asma, do you know what this is?
Angiomatoid fibrous histiocytoma.
Absolutely. It is a diagnostic case. Okay. So it is acquired, it is pathological, it is neoplastic. It is, when it's benign or malignant, it's very difficult because angiomatoid fibrous histiocytoma is one of those tumors which very, very, very rarely metastasizes. You can't call it benign. So in the WHO, they call it of intermediate type. Okay. So it's a category that is intermediate, which is neither benign nor malignant. But you put down your observations. They are plump cells with vesicular nuclei, some nuclear irregularity, no mitotic figures, spaces containing blood, and those spaces are not endothelial lined. They are just spaces. And there are lymphoid follicles at the periphery. After this talk or tomorrow, just put these into Google and see what diagnosis you get. And the diagnosis is only one, and that is? Yes, what is that diagnosis? Angiomatoid fibrous histiocytoma. So did any of you, apart from Asma, get the diagnosis? Asma, did you get the diagnosis?
Yes.
Yes, very good. Shruti?
No, ma'am, I didn't get it, ma'am.
You didn't get it. What about Gurushekar? Gurushekar, you got the diagnosis? No. Okay. Ashwin?
It was angiometric fibrous histiocytoma.
I know, did you get
Peripheral
that?
lymphocytic infiltrates.
Yes, I know that. But before you came, did you get the diagnosis?
Yes, ma'am.
Oh, you did. Very good. Then why were you so diffident to say it? And what about you, Ismail?
No, I did not.
You did not get the diagnosis. But now, if you had made the right observations, Ismail, and even put it into Google, you would have got this diagnosis. All right. So just if you want to see the immunohistochemistry, it's not required. CD31, CD34 negative, ERG negative. Note that you have an internal control. SMA, again, it's negative, and you have the internal control. Desmin, internal control, it is negative. S100 protein. So this is a tumor that is almost entirely silent. There is no marker that will regularly be present in this tumor. Okay, so you're not going to make this diagnosis by doing immunohistochemistry. If you want to use some diagnostic test, then you will have to do, an ATF Krebs assay, or you will have to do some other break apart probe to show that there is a translocation in this tumor. But you don't need that. If you have made the right diagnosis, you will reach the right answer. Okay, very good. So we had 2 lookalikes. One was a schwannoma, the other was an angiomatoid fibrous histiocytoma. All right. Now who's going to take this? Ismail, is your thing working? Will you take this case?
Right, ma'am.
All right, come on, read.
Yes, 48-year-old male, specimen with distal partial gastrectomy. Gross
Yes.
examination show the polypoid mass, measuring 0.5 centimeter in size on the Lexa curvature.
Excellent. Now come on. Describe this.
Its section shows
You know that you have to ask yourself 5 questions. Yes, Ismail, I'll ask them for you. Is there any normal tissue seen?
yes, on the left hand side and the lower part. See,
Very good. So you said the section shows, and then you didn't say anything more. So how about, let us starting with saying the section shows
the gastric tissue.
gastric mucosa. Very good. Yes.
With,
Is there an abnormality?
yes, on the right.
Very
on
good.
the
So there
right-
is an abnormality seen. Excellent. Then,
Yes.
what's the next question that has to be asked? What is the relationship of the normal to the abnormal? So what do you think is the relationship of the normal to the abnormal?
It looks like it's actually upon the subepithelial layer, although I could not actually appreciate the surface epithelium.
All right. And now here he says that he doesn't know what the relationship is. You've got gastric mucosa over here, yes, and you see that the gastric mucosa is turning around like this, okay? And then suddenly, what do you have? Ismail, what is it? It is like almost like a volcano, no? Can you see?
Yes,
this?
ma'am.
Yes, it is something that is just burst out of this. It seems like that. It's almost like a volcano. But what is it that you want to say about this? All right. So there is gastric mucosa, and it has disappeared. The gastric mucosa has disappeared. So there is an ulcer. There's a huge ulcer in the gastric mucosa, and this ulcer has got some kind of faceless material, right? It's completely devitalized. You don't see a single cell, a nucleus in any of this. And the gastric mucosa, it's almost, like I said, it is a cone like a volcano that is erupting onto the surface through this ulcer. Yes or no, Ismail?
No.
Yes, very good. Now you see it again over here. See, there is gastric mucosa, right?
Yes, ma'am.
Then what do you see here? Here is this line that you are seeing here. What is this line?
It just looks like a muscularis mucosae.
Right. So this is the muscularis mucosae. Here is the here is the remnant gastric mucosa. Yes.
Yes, ma'am.
You see that this is the remnant gastric mucosa. And then what do you see? There should have been gastric mucosa here, right?
Yes, ma'am.
But where's it gone? It's gone. So it's
Yes.
ulcerated. It is completely ulcerated. And then there is
Yes.
that ulcer has got an overhanging edge. Look at it. It's overhanging. Let's take another color if I can. I can't. Okay. That has an overhanging edge. So this is an ulcer with an overhanging edge. That whole ulcerated material is overhanging the normal gastric mucosa. Okay. Right. Okay.
Yes, ma'am.
Now, again, you see the muscularis mucosae. Yes. There it is. See the muscularis mucosae.
Yes, ma'am.
Now, are you going to tell me what is the relationship of the normal to the abnormal? Yes, Ismail, what is the normal to the abnormal relationship? There's the muscularis mucosae.
Yes,
So gastric, yes.
the ulcer is overhanging over the normal areas of the gastric mucosa.
So this is a lesion that has occurred in the mucosa. It is in the mucosa. Everything is above the muscularis mucosae, and to some extent, as we will see in a minute, yes, you see over here that there is also an inflammatory response in the submucosa. Okay, but this is a mucosal disease. What you are seeing is a mucosal disease because almost everything is happening above the muscularis mucosae, with the submucosa showing an inflammatory response. You agree, Ismail?
Very well, ma'am.
Excellent. All right. You can see this clearly here too. But what you notice about the abnormality, because we now have to say, what is the pattern of this abnormality? What is the pattern of this abnormality? What would you say about the pattern?
Yes,
But it's important. It's something abnormal, and we must say the pattern. What is the pattern of this abnormality?
it's undergoing necrosis and as well as
Yes, so it looks like something is necrosed. Yes, it is devitalized. Yeah, and here you can see that where you can actually make out some nuclei, there is this acute, it is an acute exudate that you are seeing. You're seeing this acute exudate in the gastric mucosa that is replacing the ulcerated gastric mucosa, and there is a huge amount of necrosis. All right. So now, Ismail, what did you think was wrong with this lesion? See, I've shown it to you. It's like an overhanging ulcer. You can see that here too. It's like a volcano that has erupted. So what are the salient features? Anybody has got a diagnosis? Is there anything in the chat box, Kani?
Nothing much, ma'am.
Nothing much. Okay. So number one, there's an abrupt line of demarcation, right, between normal gastric mucosa and the lesion, which pouts above the gastric surface. I told you, no, it's pouting about. You know what is the meaning of pout? No, it's like it's erupting above the gastric surface, and that material is faceless, basophilic, granular tissue. Oh, you said it is necrotic, but normally necrosis is pink. Don't you agree, Ismail?
very well, ma'am. Yes, I do.
But this is basophilic, and you can't see any cellular characteristics in this material. There's an acute exudate over the better preserved parts of the mucosa, and we saw that. It was an acute fibrinous exudate. The base of the lesion is in the submucosa because the muscularis mucosae is also necrotic. You can see that. You don't see the cell. So the base of this ulcer is the submucosa. Everything above that is necrotic, or it is showing you this faceless, basophilic, granular tissue. All right. And of course, there is the appearance of an inflammatory infiltrate in the base of this ulcer. All right. So what are your thoughts? And my thoughts would be, why can't we see the cells of the lesion? So I'll ask you, why can't we see the cells of the lesion, Ismail?
Because they've undergone necrosis. So it's
Because it has undergone necrosis. Yes. I use this term, which is a good term, and that is the tissue is completely devitalized. Okay. If you use this term, devitalization can have many different etiologies. It's the same thing as necrosis. Okay. But when you use the word devitalized, you will see that you think about many other things except for the usual reasons for necrosis. Okay. So you have to say, if it is devitalized, what has become devitalized and why has it become devitalized? Okay. So what has become devitalized is the gastric mucosa. That there is no doubt about. And what are the causes of devitalization? You can have chemical, you can have enzymatic, you can have physical, you can have vascular, you can have infection, and there can be autolysis. Sometimes, if your tissue is badly fixed or whatever, it has undergone autolysis and everything just looks completely devitalized. And all the causes that I have put over here. All right. Now, what do you think is the cause of this devitalization? You want to take a stab at it, Ismail?
yes, ma'am.
Yes, tell me. Do you think it's chemical, enzymatic, physical, vascular, infection, autolysis? Do you have any feeling for this?
I pick more vascular actually.
You would think it was vascular. All right. Anybody has any other ideas? Asma? Yeah? No? Ashwin?
Seems like a lysis, ma'am.
Lysis, yes, but what caused the lysis? You're right. Something has lysed all this. Yeah, but it has erupted onto the surface. All right. Well, we thought we should get a good history. And you know what the history says? That this patient had melena. And he had an OGD scopy done at a hospital which showed a gastric ulcer. And an injection was given at the site of the ulcer. And that injection was probably a sclerosant containing epinephrine, and this was injected on 2 occasions locally. Then he went to another hospital, and again the sclerosant was injected for a 3rd time. Why do people inject sclerosants? Any idea, Ismail?
It's to arrest the bleeding, ma'am.
To arrest bleeding, exactly. So he was bleeding. He had melena, and he was bleeding. All right. And so when he went for a follow-up 3 months later, lo and behold, this is what they found: an ulceroproliferative mass. That's what they called it in the stomach. And somebody did a biopsy and a brush cytology, and the biopsy was called autolytic tissue. And the cytology that was done at the same hospital where he had this was called signature cell carcinoma. Now, that's obviously a mistake. It was obviously not a signature cell carcinoma. Okay. So what is your diagnosis now, Ismail? What do you think? Now we know his history. What is the etiology of the necrosis or the devitalization in this case? What do you think? What do you think now? I told you the history. Ashwin? Asma?
Vascular infection.
Vascular?
I mean, infection.
Infection.
Inf-
I gave you the entire history. Now tell me.
It's chemical.
Huh? You think it's chemical? Shruti is absolutely right. It is chemical. That's sclerosant. They put in a sclerosant as well as epinephrine. Epinephrine is something to make a vessel contract, right? So yes, there might have been a vascular, cause, but it was not the primary cause. It is the continual injection of the sclerosant. Okay, so it was chemical, and there was ischemic devitalization of the gastric wall due to the iatrogenic effect of a vasoconstrictor and the sclerosing agents used to control a gastric bleed. And the question is, why was he bleeding? And so when we actually asked for this specimen and looked for this, now you know what this bleed is from. Have you heard of this Dearlefoy anomaly? Anybody? Can anybody tell me about it? Yeah, Ismail, have you heard about it? No, it is a rare but not unknown. It's not so uncommon that you do get gastric bleeding from what is called persistent caliber vessel disease. That when a vessel, which is an artery, comes towards the mucosa, it should get narrower and narrower and narrower as it gives off its branches. But in this particular anomaly, you get persistent caliber vessel disease. Now, somebody was asking me, what is the difference between congenital and acquired? Okay, this chemical devitalization, chemical necrosis, is acquired. But what do you think persistent caliber vessel disease is? Any one of you people want to answer? Do you think that is congenital or is it acquired? Huh? What do you think?
Congenital.
Yes. So this patient had this congenital persistent caliber vessel which bled at some stage. And when it bled, they tried to control the bleeding, and as a result of which, they actually devitalized the gastric mucosa. So have I answered the question of what is congenital and what is acquired? Well, in cysts and in anomalous things like vessels and so many other things, or you have remnants of things like the cloaca or Gartner's duct or some other things, those are congenital. They may be involved in some kind of acquired disease, but if there was no congenital anomaly, you would not have had the acquired disease. I hope I've explained the difference between congenital and acquired. All right. Now, there's no prizes for guessing the next one. And you know that this is an 80-year-old woman who has soreness in the perianal region. There was a large ulcer in the lower anal canal. Okay. I'm only going to show the pictures. I do not wish any of you to make a description. But once again, you can see that there is devitalization and necrosis that is widespread in this lesion. Okay. I'm sure all of you have seen this, and there is only one diagnosis. Okay. Any one of you wants to give me this diagnosis?
Enteromegahistolytic.
That's right. So this is amoebiasis. Okay. But now tell me, what is the cause of the devitalization of this tissue?
Enzymatic.
Enzymatic, physical. Yes. Who said that, Shruti?
Yes,
it is enzymatic. Absolutely. And this is anal amoebiasis. Okay. Good. Now I know that it's very late, and I'm not very sure that I should even go through the next 3 cases. But I will give you the diagnosis because I think we should end this this session. But let me ask the 5 of you over here. Did you make the diagnoses in this case? In these cases, this we can. Did you make a diagnosis? I just put this up because you had such a nice talk by Dr. Deshpande on bone disease. So I thought you should be able to make a diagnosis. I don't want you to describe. I don't want you to do anything. Just let's go through these pictures one by one. All right. And I'll ask each one of you. What do you think? Or can you just quickly tell me what is your differential diagnosis in this case? Come on. Let's start with Guru Shekhar. Guru Shekhar, this is the lower end of the femur. Are you there? Guru Shekhar has disappeared. All right, Ashwin, are you there? Ashwin has disappeared. So who's left?
Ma'am,
Okay, Shruti, tell me,
ma'am,
what is the differential diagnosis? You
ma'am,
saw,
this
you
appears-
saw that was a 60-year-old person, right? Or 67 or whatever. So what's the
Ma'am,
differential diagnosis? Yes?
Ma'am, osteosarc disappears as a lytic lesion in the
In the
epiphysis.
Yeah, so osteosarcomas occur in the epiphysis in a 62-year-old male. Shruti, are you hearing yourself? Huh? What is the age at which osteosarcomas occur? What? When do osteosarcomas occur, Shruti?
Uh,
Asma, at what age do osteosarcomas occur?
I think it's young age, no?
Young age means what? 3 years, 8 years,
I think it's after 10 years. मतलब
after 10 years of age.
Ma'am,
Okay. Ismail, at what age are osteosarcomas very common? At what age? Ismail has disappeared or is he there? Everybody seems to have disappeared. Everybody's going home for yes,
it
please.
appears in the younger age groups of second to fourth decade, like
second to fourth decade. No, so it occurs in teenagers, adolescents, and the young adults. Okay, I know that a 62-year-old man doesn't want to be called aged, but he's certainly not a young adult, is he? No.
Right.
And where do osteosarcomas occur? At which part of the bone?
metaphysis.
Metaphysis. So where is the metaphysis? Can you ask to annotate and then tell me where is the metaphysis?
Ma'am, in between the diaphysis and epiphysis, the growth plate.
So where is this lesion?
Ma'am,
Where is
epiphysis.
this? Yes, it is here in the epiphysis, and it has reached the metaphysis, right? That is the lesion. So it is epimetaphyseal, but the majority of this tumor is sitting in the subchondral position over here. All right. So what is your diagnosis in a 62-year-old man with a lesion in the epimetaphysis, which has a soap bubble appearance?
Giant cell
What's it?
tumor.
Giant cell tumor. So you have a radiolucent lesion with a narrow zone of transition in the epiphysis extending to the metaphysis and the subchondral bone in a mature skeleton. You can see this. The epiphysis is not open. If it was open, how would it look on a plain X-ray, Shruti? It would look like a black line, okay?
Yes, ma'am.
Because cartilage allows the X-rays to pass through it, okay? And the bony contours are intact. So now, what will you pick over here? Giant cell tumor of bone, right? Would you pick a chondroblastoma? No. So there's only one thing you will not pick. Because it's a 62-year-old man and pain in the left knee while walking, you would cancel out a chondroblastoma. Yes, it can be a giant cell tumor of bone, and yes, it can be a clear cell chondrosarcoma, right? And here is this clear cell chondrosarcoma. It's a beautiful clear cell chondrosarcoma. So if you really want to see it, it's got a mixochondroid background. You go on high power, you see these very abnormal looking cartilaginous cells. You see osteoid. That is the thing that one sees, and Dr. Deshpande had shown this beautifully. You see calcifying osteoid in a chondroblastic lesion at the edges, in the epiphysis of the bone, which looks so benign. All right, look at it. You can't call this benign looking on histology, but on radiology, it looks absolutely benign. And this is typical. You get this calcified osteoid that you are seeing in an otherwise mixochondroid lesion. And you know it is chondroid because not only is there this matrix, but the cells are sitting in lacunae. And many of the cells, many have got, at least in the biopsy, have got pink cytoplasms. But let's see what it looks like. All right, but when you have the histology, you have to cancel a giant cell tumor of bone, and it's not a chondroblastoma because chondroblastoma is benign. So there's only one lesion that is left, and that is clear cell chondrosarcoma, based on the radiology and on the histology. And then this, of course, was resected. You can see that they removed the lower end of the femur. Okay, and this is how the resected specimen looked. I'll just show it to you because it's beautiful. Look at this subchondral. This is the articular cartilage, and you begin to see these seams of osteoid, which is very, very, when you see osteoid, you see osteosarcoma, and this is an obviously malignant lesion. But this is characteristic of a clear cell chondrosarcoma, and I will show you, why it is called a chondrosarcoma. You can see that there is this pink, you might call it osteochondroid if you wish, because the cells are sitting in lacunae, whereas the matrix color is pink. Okay, and you look at this. Anywhere else you would have called this osteoid, but the cells are sitting in lacunae, and this is calcification in that osteoid, which is typically seen in a clear cell chondrosarcoma. And I think you can appreciate the clear cell nature of this lesion. Okay, and it's very obviously malignant. You can see that there are binucleated cells, etc. This lesion also had hemorrhage. You saw the, I should have pointed it out to you in the gross. There were hemorrhagic areas, and these hemorrhagic areas are aneurysmally dilated vessels, but it's not an aneurysmal bone cyst. It cannot be. Why? Because all of these septi are made up of malignant. So it is a telangiectatic area in a clear cell chondrosarcoma. Right. So we did all these observations on histology. And yes, does the diagnosis of clear cell chondrosarcoma hold? It does, because clear cell chondrosarcomas are S100 protein positive. Okay, they can be mistaken on imaging for chondroblastoma and vice versa, except that chondroblastoma does not occur at the 3rd to the 4th decade. Okay, chondrosarcomas occur in young adults, and here you see S100 protein that's positive. All right, now you can see the next case. I'll just show it to you quickly, and I will discuss it because I think there is an overlap in these diagnoses. You see that again? It is in the epiphysis. Again, it is such a clean, well-circumscribed, narrow zone of transition. And here, this is not in an elderly person. This is in a 27-year-old female. And all of you actually saw this histology. Okay, now this is an MR, and you know that in an MR, in the T1, you get a black cortex. Okay, so this lesion is not black. Therefore, this is not mineralized tissue. Okay, and it's the opposite in the T2. And here, this is like something that is not. Again, it is not mineralized tissue. So here you are, sharp radiolucency at the lower end, which is again metaphyseal, and you have your 3 differential diagnoses of these lesions at the lower end of the, in this case, also the lower end of the femur. And which would you think of now in a 27-year-old person? You would cancel out, because it's 27-year-old, you would cancel out a giant cell tumor, you would cancel out a clear cell chondrosarcoma, and you would keep chondroblastoma as the first diagnosis. Okay, but when you look at the histology, yeah, there's cartilage, but this is not the cartilage that you see in a chondroblastoma. And you've got giant cells, but an extremely cellular tumor. Yes, very, very cellular. And there is very malignant looking cartilage that is present. There is also these giant cells, and there is no doubt there are mitoses and everything. So this is a malignant tumor. This is not a chondroblastoma. It cannot be. Although there is cartilage, and we just saw a clear cell chondrosarcoma. So then you might think, this is a clear cell chondrosarcoma, except that it is occurring in a 27-year-old. No, it is not that. You never see these many giant cells as you've seen in this, and this is not the kind of cartilage or bone that you see in a clear cell chondrosarcoma. You see those nice cells sitting in lacunae, which you're not seeing over here. Right? Look at this. This looks for all the world like an osteogenic sarcoma. But what is an osteogenic sarcoma with giant cells sitting in the epimetaphysis? And here it just looks very, very malignant. Okay. So once again, after seeing all this histology, and you have these 3, it cannot be a chondroblastoma. Okay. You have to rule out all 3 because it doesn't look like that. So then what actually is this? Well, it is an osteosarcoma. You can see that. I mean, SAP-P2 doesn't tell you anything, but there is a mutation-specific marker for primary malignant giant cell tumor of bone. It's not for primary malignant giant cell tumor of bone. It is for any giant cell tumor of bone, whether it is benign or it is malignant. And this is 3.3 G34W. And so we did it, and you can see that the stromal cells, the giant cells never show this. The stromal cells show this, and therefore this is a giant cell tumor of bone that is primarily malignant. Okay, so you must remember that sometimes appearances can be very, very deceptive. Then I showed you, I don't know if I said you this, but this is a 17-year-old male who has mild pain and swelling in the right knee for 10 days. Once again, you see that here it is entirely in the epiphysis. Okay, it's not in the metaphysis at all. It's in the epiphysis, and you can see clean, nice area, which is partly sclerotic and partly lytic. And here, once again, you see a very cellular tumor. You see a portion of cartilage down here, but that cartilage is probably from the epiphyseal cartilage. And you see chondroid areas in between. Okay, and now I want you to concentrate on this area, which I will give you. I'll just tell you which area I'm talking about. This is the area that I want you to concentrate on. And now, when you look at it, see the chicken wire calcification that is being seen in this very cellular area. Looks frightening, but this tumor is a classical chondroblastoma. So I've shown you. And why did I even keep this? Because chondroblastomas today also have what is called a mutation-specific marker. And that mutation in the giant cell tumor occurs in a histone, which we call G34. Here it is occurring in K36. And I'm not going to go into this. I mean, if anybody's interested in histones, you can look at it. But this is the histone, H3. And that's why we said H3.3. All right. So here is H3. This is the mutation that occurs in a chondroblastoma. This is the mutation that occurs G34 in giant cell tumor bone. And there is another locus on the same tail of the histone. You know, if you look back, you'll see that all these histones have a tail, and these mutations are occurring in the tail of that histone. And when it occurs in K27, these 2 are expressed. The mutation-specific protein is expressed. Here, the mutation-specific protein is lost. Okay, so when you get this kind of loss, it often is seen in MPNST. It's not only in MPNST. Today, you know that brain tumors, we are looking for histone-specific losses and gains even in brain tumors. So I thought you should know a little bit about histones. Okay, and this is to tell you that even radiology, we say that we must compare it with radiology, we must corroborate what we are seeing on histology, but radiological appearances are no more specific than histological appearances. We must remember that. So clear cell chondrosarcoma, which looks like a chondroblastoma, which looks like a malignant giant cell tumor. Okay, so thank you for being patient, and all of the students who are there. Thank you from Alice, Tweedledum, Tweedledee, and me. I will stop sharing, and if there are any questions, I will be very happy to take them. Good. So Asma and Ismail, did you enjoy this? And Shruti?
Yes, ma'am. It was very helpful. Thank you so much, ma'am.
Okay.
All right. It was quite interesting. Thank you very much. God bless you.
Thank you, Ismail. Now tell me, can you tell me if there are any questions that haven't been answered and they are in the chat box?
Thanks a lot for the wonderful question, ma'am. There is a question. Is there any significance of presence of some clear cells in 3A?
Clear cells
In 3A.
3A. What was 3A? If somebody will remind me, then I can tell you. What was 3A, Asma?
3A. I don't know.
Yes. Oh, I know. Yeah, this 3A was the schwannoma. Okay. What is the significance? There's no significance, but except that it is seen in schwannomas, and therefore it has a diagnostic value. All right. You see that in the Antony A and Antony B areas, in the ones where you have few or the cellularity is low, you often have these clear looking cells. So that's the only value. It's not there may be a diagnostic significance, but there is no other value to this these clear cells.
One more question is there, ma'am. Is dog one necessary in GIST?
Necessary in GIST? It is a very important part of your diagnostic armamentarium because you may not get c-kit. All right. You may lose STH. You know, STH is a is succinic dehydrogenase, and there are gastrointestinal stromal tumors that do not express c-KIT but have lost succinic dehydrogenase. Now, the only thing in common with both of them is that they express DOG1. So it would be very, very unwise not to do DOG1, because there are very few, less than 3 or 5% of GIST that do not express DOG1, but there are many wild-type c-KIT tumors, and one of them is a succinic dehydrogenase type tumor, or even one that has lost, that has mutated a PDGFR gene. So DOG1 is common through all of them, except for a very small number of gastrointestinal stromal tumors that do not express DOG1. But there are a whole lot that do not express c-KIT, because there is PDGFR that may be mutated, or there may be a succinic dehydrogenase deficient tumor. So please do DOG1. It's very important.
Yes, thanks a lot.
All right. Is there any other question?
No other questions.
All right. Excellent. It's been a long journey. Thank you, Atma, for waiting up. And Ismail, it's not so late for you. For us, it is 10 o'clock, almost 10 o'clock in the night. All right. And thank you, Shruti. And I don't know what happened to our 2 other intrepid guys. Maybe they lost their connection. But thank you to Ashwin as well, and to Guru Shekhar. All of you have been really, really good. Okay. And all of you got the diagnosis. Was it very difficult? The answer is no. You just make the observations and the diagnosis flows. And as I said before, if you make the right observations and you don't know what it is because you've never seen it before, just go to Google Baba and put your good observations there. If you make wrong observations, even Google cannot help you. Okay. So it's the right observations, the right interpretations, and there you will have the answer. Okay. But do this in a logical, systematic way. Just don't go all over the place. If you're describing cells, then describe the cytoplasm and all the features of the cytoplasm to yourself, all the features of the nuclei to yourself, rather than just look at one thing and go jumping around from one to the other. Systems, that's what you need. And then everything else is easy. Thank you so much, all of you. It's been a long day, so I will wish you all thank you, Narasimhan, and Kani. I cannot thank you enough, because you always step into the breach when needed. So thank you, Kani, and I hope that we are all ready now to have our dinner. Good night.
Thanks a lot.
Thank you.
Bye.
Just a gentle reminder about the upcoming session on 2nd of May on normal histology of the lymphatic system and approach to non-investigations by again Dr. Anita, ma'am. Thanks a lot for attending. Good night, everyone.